like to once again welcome you this evening to the Perimenopause Menopause Bootcamp presented by WellFemme. And I would now like to introduce to you Dr. Kelly Teagle and Dr. Katie Kent. Now, our first presenter, Dr. Teagle, she blundered her way through early menopause at 42 years of age. And this experience really inspired her to help other women through this time of life by creating WellFemme and the Telehealth Menopausal Clinic. So please say hi to Dr. Kelly Teagle. Welcome, Kelly. How are you?
Hi, thanks, Michelle. Hi, everybody. I'm so amazed to see all these incredible women that are logging in to join us tonight from all around the country. So welcome, everybody. I'm really looking forward to getting some opinions and ideas back from you.
Absolutely. And we also have Dr. Katie Kent, who's a GP of over 20 years, and she has a background in contraception and sexual health medicine. She developed a special interest in menopause medicine in the UK, and she's lucky enough to meet some like-minded GPs and joined WellFemme when she moved here to Australia. So welcome, Katie. How are you?
Fine, thank you. Hello, everyone. Looking forward to meeting you all.
Okay, so Kelly, for many women, menopause is kind of a fairly problematic time. Can you tell us about that? And more importantly, what can we do about it?
Well, you're in the right place because Katie and I have got a presentation plan that'll go right through all of that. So I might just launch straight into it because it gives us a bit of a structure to it, and we can go right from the beginning about what menopause and perimenopause are, how it affects you, and what you might be able to do about it. So without further ado, I'm going to move on to our presentation. Now, while we're on this little bit here, some of you may have seen this amusing slide before and can identify with some of these dwarfs here on the screen. I'm going to try something new that I haven't tried before, and I'm going to ask you girls a question, and guys, maybe you're a dwarf as well. So I'm going to ask you to answer a question for me. Which dwarf is most representative of you? You might be able to see the answers there. We've got some itchy and bitchies, and Sweaty's taking the lead now. Forgetful's catching up though. This is like watching the Melbourne Cup. Oh, that's funny. Well, there's lots of Sweaties and there's lots of Forgetfuls. So obviously there's lots of you out there that can identify with the dwarf. So we're going to talk to you a little bit about why these symptoms happen and what you can do about them as we go through. So, yeah, thank you very much for answering those questions. I'll close that poll down. All right, so back onto it. I'm going to now just tell you a little bit about what we're going to cover. So first, as I said, we're going to just discuss what menopause and perimenopause are. We're going to talk about the symptoms. Most importantly, why you need to optimize your health at midlife to get the best quality of life as you age later, and about the screening activities that you need to be doing to ensure the best health as you age as well. We're going to talk about the different types of treatments that are available and how we can target specific symptoms, and why menopause is actually really cool and you shouldn't fear it at all. So without further ado, my learned colleague, Dr. Kent, will launch into what menopause is all about.
Lovely. So menopause is normal. All women will go through menopause. It means it's a diagnosis that you make looking back. So it's looking back at your last period when you've not had a period for at least 12 months. And most people will reach the menopause between 45 and 55 years of age, but not everybody. 10%, so 1 in 10 people are outside that age range, and 1% of people are under 40 years old. So there are lots of reasons for menopause to happen. It can just be the way you're built, which is what we call physiological, so where your body works. It can be medical, so things, medicines that you take or chemotherapy or that kind of thing can induce a menopause, or surgical. So most typically having your having a hysterectomy and your ovaries removed can cause menopause at that point in time.
Yeah, and that's important too, Katie, that what you were saying just there about most women will go through it between 45 and 55, but there is like about 5% that go through under the age of 40, right? And that can have really serious implications potentially for their heart disease risk and bone health later on in life too.
Yeah.
Okay, so just with regard to symptoms, this pie graph here sort of shows you the percentage of women that will get symptoms related to menopause. And what are we talking about here with symptoms? We're talking about things that you may recognize, and some of you bloaties and flushies and sweaties and things might recognize. So hot flushes or night sweats, sleep disturbances, you might get changes in your sexual function, vaginal dryness or pain, musculoskeletal aches and pains, the dreaded brain fog or cognitive difficulties, urinary problems. So there's actually quite a spectrum of symptoms, and you'll see more of those on a chart later. There are about 20% of lucky women that don't get any symptoms at all, but the vast majority do. And of the women who get symptoms, about 20% of them are quite severe symptoms that can be fairly debilitating. This little bit down the bottom in the pink arrows just shows you like a little bit of what that whole menopause transition's about, that you start out with perimenopause, which is the lead up to your actual menopause when you stop ovulating. And perimenopause can go for around even up to 10 years and even start before you actually see any changes in your period starting to happen. And then, you reach menopause itself. As you progress through the perimenopause, you might notice your periods getting more erratic, further spread out. You might go for quite long periods of time without having a bleed. And then all of a sudden, you seem to have stopped. And then 12 months later, you go, well, that's it. I'm postmenopausal. Hurrah. So that's your transition there along the bottom of the screen. Okay.
So in terms of symptoms, sometimes it's hard to know that you've reached that part of your life, because obviously you can still be having regular periods, but you can still be perimenopausal. So it's worth knowing what symptoms to look out for, and worth knowing that your symptoms can start well before your last period. So most women have around 3 to 6 years of symptoms, but some women's symptoms go on for more than 10 years. And up to 80% of us will have menopausal symptoms at some time in our life. Women in their early 50s report moderate to severe hot flushes in around 50%, but most of these women, a massive 85% of them, are not being treated for those symptoms.
So on that one, I've got another question here related to symptoms, and I might pop this up as a poll question as well, just to see who in the audience actually is having one of these particular symptoms. Guys, I guess this question doesn't really relate to you so much. Oh, lots of hot flushes and night sweats, quite a few mood problems. Oh, sleep disturbance is always a huge one, isn't it? So we're getting quite the feedback. And of course, you don't just get one of these things. You can often get loads of these things all happening together, which is a delightful little concoction, isn't it? Plenty of sleep disturbances. Look at it. It's out in the lead for sure. Interestingly, in perimenopause, I don't know about you, Katie, I noticed that in the perimenopause, even if women are having quite regular periods, they might be complaining of mood changes, sleep disturbance, and migraines particularly starting to get worse. Do you notice that?
Yeah, I notice particularly those things, and also achy. A lot of women say they're achy in that perimenopause period as well.
Yeah, and sore feet. Lots of ladies are telling me sore feet. That's a thing, isn't it? Yeah. Okay, great. Well, let's go back to the presentation. All right, so we were talking a little bit about, how many women are having these symptoms, and we know about 80% of us will. So at any given time, looking at the age group of women 40 to 65, there's been studies done here in Australia on the Australian population of women particularly, and just going by those numbers, there's about, nearly 500,000 women who get moderate to severe, it says VMS, which is vasomotor symptoms. That's hot flushes and night sweats. And unfortunately, only around 15% of women who are getting quite debilitating moderate to severe hot flushes are actually on any effective treatment, which really blows me away, because I know, that, there are treatments out there that are super effective and safe, and women just don't seem to know about them or get connected up with them. So this is really interesting to me. Nearly 400,000 on around, based on 2016 numbers, that are having moderate to severe vasomotor symptoms that are going untreated. And that's a lot of sleepless nights and women who are struggling to get through their day. Right.
Kelly, can I stop you there for 1 second? Just in regards to bloating, stomach and bowel issues with menopause, can you explain that a little bit more? How does that all happen?
Well, that's a really tricky one. So my observations are that the hormonal changes that are happening at menopause impact on every part of your body, including your gut. So you've got to remember that, if your hormones are changing, that's impacting on the hormone receptors in the gut. It's changing the pH of the gut, the amount of acid there, and that's going to impact on the microbiome inside the gut. So, you would imagine from that it's going to change the way you process food. So even foods that you've been able to quite happily eat before, you might be struggling with or having new food sensitivities to. What do you think about that, Katie? Are you noticing something like that too?
Yeah, I agree. I mean, it's always worth checking out any new bowel symptoms and making sure other things aren't contributing to it. And I would say in general, women find that their weight distribution changes. So their weight gets centered around the middle a lot more. So they feel more bloated around the middle, as well as gaining weight in that area, which perhaps they had more on their hips and buttocks when premenopausally. So women tend to gain weight, put it around their middle, and bloating's a really common thing I see a lot of. So yes, I think it definitely can cause it, but always exclude other things causing bowel symptoms as well. Yeah,
for sure. Yeah. I think this is your slide, Katie.
Oh, yes. So, yeah, every single one of us is unique. We're all absolutely unique beings coming from different backgrounds, different life experiences, different social circumstances. And your journey through the menopause is also going to be unique. So we're all going to have different levels of fitness, different diets, different health background in health generally. We're all different people with different personalities, and how we deal with things is completely different, and how we experience things is completely different. So it's really important that you deal with what you actually get and experience, not what you think you're going to get.
That is so true. One of the difficult challenges about treating menopause, but also one of the exciting things about dealing with menopausal women, is that they're all so different. So, there's no one size fits all approach, is there? And I know that if we try different hormonal products or different treatments, or, just different advice with different women, that it's going to impact on each of them quite differently. So one lady might get a really good result without any side effects, and another one might feel terrible on it and it doesn't work for her at all.
Absolutely. And it's a matter of just trying to find the thing that's right for you. And it might be that things need to be tweaked a little bit, but it's just remembering that everyone's an individual who responds differently to
Right. Which demands a holistic approach, right? We can't just sort of say there's one, we give you one medicine and everything's all of a sudden wonderful, because everyone's a product of all the psychosocial stuff and all of the environmental stuff, and, whether they're having a happy marriage or not, or whether they've got a lousy job. So everything impacts on how bad the symptoms are and how they're perceived.
Yeah, absolutely. Everything's intertwined. So it's everyone is unique. We have to treat everyone differently. Yeah.
I just put this slide in just to show everyone, and the people who've been through WellFemme would have seen this list of symptoms previously. It's a really good idea when we're assessing a woman's symptoms to get them to show us just how severe they perceive their symptom to be, to find out what their priority is and what's the worst symptoms for them. So by doing this little questionnaire, we get a bit of an idea up front where the worst symptoms are. And it also gives us a basis that if we do an intervention or a treatment, we can actually go back later and redo the symptom score and just see which things are being fixed and which things aren't, or what's worse or better. So it's nice to be a little bit scientific about it wherever we can.
Right. So obviously we can help with the medical side of things and the prescribing things, but it's really important that you optimize your lifestyle. You're going to be healthy from what you do, what you eat, what you do in your life, and you know, doctors and your GPs, and we can give you advice on that. But in that sort of perimenopause and menopausal period, it's really important to try and eat healthily, manage your weight, make sure you have a good diet. Your bones can be affected in the perimenopause, so make sure you have adequate calcium, aiming for around 1 gram of calcium a day in your diet, and a good all-round balanced diet. I think we're going to go into activities and things in a little bit more detail, but it's important to keep your cardiovascular health up, but also your bone strength and muscle strength up. It's really important to factor in time for rest, relaxation, me time, and being able to focus on your relationships and those around you as well.
That's so true, Katie, because, you know, at menopause, physiologically, it's a big turning point, right? Because of the decline in estrogen causes the heart disease risk to rise and the bone density to drop. So all these physiological changes are happening that are really going to seriously impact your health in decades to come, unless you get on top of this stuff around the perimenopause.
Yeah, you need to be a little bit proactive about it all as well. So yeah,
absolutely. And just on that, it's, you know, when we're considering what activities we should be doing, what food we should be eating, you know, for my money, we need to be very focused on those risks going forward with the heart and the bones. And so I found this very interesting from the Jean Hales, and there's an article based on this in our blog page as well. That different exercises are actually better at building bones than others. So if you're getting some jolt forces through your skeleton, it really helps to build new bone, because the bone cells will be stimulated to lay down new bone. And so things, as you see on the left-hand side of the table there, those are the ones that build bone the best, because you're running or jumping a little bit. Whereas the things that are on the far right, not so much, you know, not so much jolt forces through the skeleton, and therefore not so good at building bone.
So heart disease, that's a really important one. It's the leading cause of death in Australian women. It caused 1/3 of all female deaths in 2016, with the data there. Women tend to present later than men, and that's because our estrogens are protective. So once we go through the menopause, we rapidly catch up with men in terms of heart disease. And often women have worse outcomes than men, because women don't think of heart disease affecting them quite so much. But it's you're 3 times more likely to die from heart disease than you are from breast cancer. And it's really sad, because actually we can prevent heart disease, we can treat heart disease. We just need to know what risk factors are and be able to proactively manage the ones that we can change. And in the perimenopause period is the ideal time to do that, as our hormones start to change.
Yeah, this is an example of what you're talking about right then, Katie. So there are risk factors, obviously, that we can't do much about. You can't change your gender or your age or your ethnicity, and you can't choose your parents. I know a lot of us, you know, probably would have liked to have had that opportunity. But yeah, when it comes to things you can change, things that you can do something about, there's loads of them, and they're largely, you know, obviously lifestyle things. So you know, these are things that we can be helping women, advising women about, but it's very, very important that they work really closely with their regular GP on this, because it's going to require some effort over time to do some of these things. On to screening activities, Katie.
Oh yes. So around this point in your life, around your midlife time, it's worth lots of screening is available through your GPs. It's worth getting a cardiovascular risk assessment with your GP. They can look at your weight, they can look at your smoking, they can have a good update of your family history, they can screen you for diabetes, they can check your body mass index, so your weight to height ratio, they can measure your cholesterol levels, and make sure you're up to date with all your pap smears and your breast screening at that point in your life as well. So yeah, screening it's a really good opportunity to do it, and you know, be quite proactive going to your GPs and making sure those tests are done and speaking to them about it. and taking things forward.
Yeah, absolutely. There used to be, and you might know this, Katie, there used to be a GP item number for the 45 to 49-year-old health check. Is that still available?
That's still available, yes. So there is an item number. So your GPs are usually really pleased to see you about it and really happy to see you and are keen to get the screening done. So whether that's done through your GP themselves or through the practice nurse, it's worth contacting your GP surgery and getting everything up to date, so your sort of general health is tackled and you're as fit and healthy as you can be going forwards.
Yeah. What's your recommendation to women about breast screening? What do you tell them, like when to start?
So it's actually funded from age 40. I'm in New South Wales, so certainly with Breast Screening New South Wales, it's funded from 40, but actively encouraged from 50. And we say from 50, every 2 years, you can do it directly through Breast Screening New South Wales in my case, but I'm sure it's the same in every state. If you've got a strong family history or you're worried, you can get screened from 40 under that program as well. But if you're worried at any point, it's always worth it to be breast aware and breast check. You don't have to wait the 2 years. Always go and see your GP and get things checked out if you're at all concerned.
Yeah. And any women there who are holding, I'm hearing an echo. Are you hearing an echo? No? For any women out there who are holding off on getting pap smears because they don't like them, the good news is that they're 5 yearly now. So the cervical screening program's now 5 yearly. And so if you, go and see a lovely doctor that you trust, go and get your cervical screening up to date, and then that's it for 5 years. You can relax.
Yeah.
Kelly, can I ask you a question just in terms of what do you advise if a GP, you kind of go and speak to your GP and they don't kind of appear to be that interested, or they're a little bit dismissive of the symptoms? What do you recommend people do?
Yeah, that's a tough one. And I think, I do sometimes hear ladies saying that they feel like they've been fobbed off or that their GP wasn't willing to engage with them in that conversation. I do think it's important to acknowledge that GPs aren't experts in absolutely every area of medicine. And that's, those of us who are drawn to this particular area have chosen to sort of upskill, so that we know more about it. But I feel that you do need to be a good advocate for yourself. If you're not getting the answers that you want, push them a little bit. Go away and have a look on the Australasian Menopause Society's website or our blog page, or the Jean Hale's website. Get your information, get your facts straight, and then take them along and say to your GP, oh, look, I was reading about this. Is that true? Try and push them a little bit, because I think a lot of GPs will pull away from the conversation if they don't feel confident with the discussion or they don't feel confident with treating menopausal women. So you do sometimes have to advocate for yourself, or maybe even go to another GP. What do you think, Katie?
Yeah, I mean, I would say all GPs have areas that they're more interested in or more familiar with than other GPs. And I think, even if you've seen your GP for 20 years, they're not going to be offended if they can't meet your needs and you see another GP for that particular area. If your GP's not meeting what you need, it's really important you don't give up. So do go and see another GP in the practice, or obviously, we're here if you need it. But you don't have to feel loyal to your GP if they can't meet what you need at that point in time with that particular area. I would just try and find another GP, or even ask your GP, do you know of anyone who has a special interest in this area I could go and see? And and often GPs really do want to help you, so they'll hopefully point you in the right direction if you do that. So don't be shy about coming forward and doing that.
Yeah, in fact, the Australasian Menopause Society, the AMS, actually has a Find a Doctor page on their website. So for people who are looking for a menopause doctor in their area, in their local area, they can actually look state by state to see which doctors are members of the Australasian Menopause Society. So that might be helpful as well. But I agree, Katie, it's really common. And in my own practice, if someone asks me to look at their skin lesions or something like that, I'll send them along to one of my colleagues in the practice who's much better at that sort of stuff. So yeah. GPs, with the breadth of medicine, we're much more, on board with now cross-referring to colleagues who have more skills in a different area.
Yeah, ultimately you need to find the best person to meet your needs, and that might mean just looking around a little bit further than the usual person you see. And I think the vast majority of GPs are massively supportive of that. So
yeah, absolutely.
Just one more little quick question, and everybody loves the cartoon, by the way, that's on the moment. If your GP has kind of said to you, look, they don't prescribe HRT, and I know we're going to get to that, but there's just been a couple of comments that do we really want to take another pill, and some of those kind of comments coming through from GPs telling people this. What advice do you give in that regard?
Katie?
I mean, I think if your GP has said that to you and they're hesitant to prescribe, I can just reiterate, speak to someone else. You know, HRT in most cases, we'll probably get onto that in a little bit, but is very safe to prescribe. We're only replacing what you'd naturally have anyway, so it's not really adding to your medication list vastly. I think it's really important that you do seek help and don't just take that as acceptable. Make sure you've explored all the avenues that are open there to you. And even if one GP can't help you, don't give up. Make sure you go and speak to someone else. Yeah.
Absolutely. So moving on to screening activities and the manogram down there. So with respect to bone density, I think it's really important to think about whether you're at risk of osteoporosis, because as we mentioned, from menopause onwards, then you can get a big drop in your bone density. Around 15 to 20% of bone density can drop in the first 5 years after menopause. That's how much of an impact low estrogen has on your bones. So if you're already at risk, if you've got a strong family history, or you've had medications for chronic diseases like, steroids for rheumatoid diseases or autoimmune diseases or something, or you don't eat a lot of calcium, particularly if you're slim or you're somebody who's prone to fractures, or you had a really early menopause or lost your periods for any length of time during your life, these could be risk factors for osteoporosis, and it might be worthwhile asking your GP for a bone density scan. And then there are other regular screening activities to think about just as we get older, which is things like bowel screening, where you get your poo checked to see if you're pooing blood at all, which could be for a bowel cancer. Skin checks really super important, because who of us when we were young wasn't running around the beach in the nutty? And STI screening, don't think that just because you're older you're immune to chlamydia, ladies, because a lot of us are out there now, repartnering and doing internet dating and getting new partners. So still, the rules still apply to us as well. You still need to be using condoms with new partners, and you still need to think about getting regular STI screening if you're changing partners. And we already mentioned the 45 to 49-year-old health check there as well.
Yeah. So also just remember that things that you can do to help with your symptoms before you even get to the point of seeing the GP. With your hot flushes, if you identify triggers, try and avoid them. Have layers of clothing that you can take off or put back on if need be. Environmental control, things that are obvious like fans and air conditioning can make a difference. Make sure you treat all other medical conditions, keep all of that up to date. Be mindful of things other than menopause causing depression. Make sure that you're proactively treating them with your GP as well. Vaginal dryness, you can, lubricants, moisturizers that you can buy over the counter at the pharmacy can be really helpful with those. And vaginal estrogens are worth talking about with your GP as well, because they can be applied very safely directly to the area and make a massive difference for vaginal dryness, particularly, even if you are or aren't using HRT. You can use that in addition or separately. Is that right, Kelly?
Yeah, and I would say pelvic floor physios too. I didn't have that on the slide, but yeah, pelvic floor physios are fantastic at helping women who have sexual pain and, anything that's going on down there that might be related to menopause or aging. It's really good to get an assessment from an experienced pelvic floor physiotherapist.
Definitely, yes. And also to remember, just because your periods are changing or they're becoming less frequent, you can still ovulate, so you can still get pregnant. So you do still have to think about contraception. It is lower risk, but it's not no risk. And I do see lots of women who just assumed that they weren't having periods because they were going through the menopause, and actually we found, they found themselves to be unexpectedly pregnant. So do think about contraception going forwards. And obviously, as Kelly mentioned in previously, sexually transmitted infections don't go away as you get older. So new partners, always keep up to date with your sexual health screening. Libido and sex issues. I hear this really frequently. Libido seems to be massively affected in the perimenopause and menopause. So it's really important to focus on, relationships, other things that might be feeding into that. It's a really quite a complex area, but it's important that you seek help if you are struggling with that as well.
And there was a line there about period problems too, Katie, because I'm sure you're the same. You see heaps and heaps of ladies who are having irregular periods, and also because they're irregular, they're also super heavy by the time they do have them. So it's a big thing that women will be having much heavier periods and very irregular periods. So we need to often treat that, don't we?
Absolutely. I mean, people's cycles change quite dramatically in the perimenopause and menopause. So heavier, more prolonged periods. Sometimes they become shorter and lighter, but everybody's different. So heavy periods can definitely be managed well, and it's really important that you do seek medical advice for that and don't just put up with it.
Now, okay, so just mood symptoms, there is a lot of the obvious lifestyle things like relaxation, mindfulness, meditation, exercise, so we don't at all leap straight into going, oh, you need to have some antidepressants. There's actually, mood symptoms are very, very common at hormonal times of life, as anyone with a 15-year-old daughter like me will know. And they call menopause the reverse puberty, don't they? So it's very much about, with the perimenopause particularly, you can have the mood symptoms even before you're having any flushes and things like that. So definitely be focused on what you can do in terms of looking after yourself and your mental health at times like this when everybody's, locked up at home and out of routine. It can be really, really stressful. So really look after yourselves. Medication is always an option, that could be considered, and obviously is considered frequently for people with very severe depression and anxiety. But there's many, many things that we can guide you through, and a good psychologist is gold in that sense. With regard to sleep, same, you need to be maximizing and optimizing your sleep hygiene, which is things like making sure that you're going to bed and waking up at regular times, you're avoiding screens close to bedtime, you're having nice calming music in the background and dimming the lights close to bedtime rather than getting yourself all amped up with bright lights and exciting kind of movies and things like that. So yeah, think about that. Think about the things that will help to promote sleep, having a nice warm bath as you're approaching bedtime. And then as your body temperature drops, it helps to ease you into sleep. And there are some medications that we can use to help with that process, like melatonin, which is a hormone that helps to prepare your body naturally for sleep. Sometimes it gets more severe. You need to see a sleep specialist, get a sleep study done, or consider using different kinds of medications. So it's a very stepwise lifestyle, holistic approach to sleep as well. Then with respect to urinary symptoms, we've already mentioned pelvic floor physiotherapists. They're not only fabulous with vaginal pain and problems, but also with urinary and bladder issues. So they can talk you through bladder training. They can talk you through what you should be, what your diet should be not including. If you're having trouble with bladder frequency, for example, they can do loads of things that way, and they can teach you your pelvic floor exercises. The vaginal estrogens can be helpful for women who are having urinary frequency, and there are a range of other more medical approaches that we can take as well. But in very severe cases, particularly with stress incontinence caused by pelvic floor damage, it might actually be a job for a gynecologist that specialises in that area. So again, depends on kind of the severity. But we did actually do a webinar last year, in fact, about bladder issues around menopause. And my friend Marita, who's a pelvic floor physio here in Canberra, was co-hosting that one, and we talked a lot about the different approaches to fixing your urinary issues. So check out our blog page if you want to have a look at that. The big question of the day, Katie, over to you.
Yeah, so hot flushes. I mean, as we've touched on, these affect a huge number of peri and menopausal women. The HRT is the most effective treatment. We know it works really well. It's kind of the fluctuations and dropping of your estrogen levels that cause the flushes and sweats that you get. So by kind of stabilizing those, it can massively reduce them. But some women can't use HRT, and there are lots of options that we can try if you're unable to have HRT for whatever reason. So most commonly, if you've got a history of breast cancer, if you've had previous blood clots or cardiovascular disease, and you need to speak to someone and get a very careful history taken, but also some really active rheumatological disorders like lupus, or if you've got a very high cardiovascular or your risk of heart attack or stroke, again, that needs to be taken very carefully into consideration, and a balance of what's going to be safest and best for you discussed. So when you start HRT, it's always it's good to be mindful that your bleeding patterns can change, and it may take a few months for things to settle down for you. With HRT, if you don't have a uterus, if you've had a hysterectomy, you only need estrogen. But if you've still got your uterus, you need progesterone as well to protect the lining of the womb. So the best and safest way to give estrogen, I think, is through the skin, so transdermally, because it's got no risk of unwanted blood clots. It's got zero increased risk of stroke, giving it that way, and it gives it in a nice steady level. So I use transdermal estrogen a lot, although oral HRT for some women is their preference, but transdermal estrogens generally safer. Some progesterones increase the risk of breast cancer, but not some of the newer progesterones like prometrium, again, which is one I use a lot. And the Mirena coil, if you've got heavy periods, that can also protect the lining of your womb, reduce your bleeding, and has a lower breast cancer risk than some of the other progesterones as well. HRT in general is usually safe to start in the perimenopause, or certainly within 10 years of the menopause. It's generally considered safe, apart from very specific conditions, which obviously you would discuss on an individual basis. Really beneficial for bones, that keeping that estrogen level steady stops bone loss. It reduces your risk of plaques forming in your arteries if given around the time of the perimenopause. So because it actually improves your cholesterol profile. It's protective against bowel disease, endometrial cancer, and all-cause mortality is also reduced by starting HRT. So loads of positive benefits of being on it.
And they don't talk about that very much, do they? It's all the focus has always been on, it's going to give you blood clots, it's going to give you breast cancer, which has been very, very mispresented, because really, it's been very unjustified, the sort of bad name that HRT's gotten over the years, hasn't it?
Absolutely, yeah. And with the newer HRTs and giving it transdermally, so through the skin, again, that saves the risk of taking it's even lowered. So it's really got really good benefits to it.
Yeah. I mean, when it comes to breast cancer risk, and I like to make this point, Katie, when I'm speaking to ladies myself, is breast cancer risk for women in Australia is about 1 in 8. About 1 in 8 of us is going to get breast cancer in our lifetime, right? So that's pretty frightening in itself. It certainly demands a certain level of vigilance when it comes to your screening activities and doing your breast self-examinations and that kind of thing. So, that's 1 in 8 women who are on HRT. It's 1 in 8 women who aren't on a HRT as well, who are going to get breast cancer. So I think the important thing is if we're choosing the right products, because it's clear from this that, it comes down to the choice of products as to whether or not there's any increase in risk at all, really. And if we're using the right products, then really it's not all about whether or not there's any increase in risk of developing breast cancer. The important thing, I think, is to make sure that if you are the 1 in 8 who develops a breast cancer, that you get off the hormonal treatments right away. So, you know, I think the emphasis needs to be shifted on, don't be frightened of any increase in risk from the HRT, because it's really, really low. If you're 20 kilos overweight, ladies, you have doubled your risk of breast cancer right there. So lifestyle factors are really way more important. So don't be worried about whether or not the HRT is increasing your breast cancer risk. Just worry about making sure you're being very vigilant with your screening. Make sure you go and see your doctor and get any new lumps checked out and maybe biopsied if necessary. But yeah, I think that, you know, on balance, if somebody's, you know, around perimenopausal age with debilitating symptoms, it's certainly very safe for most women to at least do a trial on it and see if they feel better. Would you agree?
Yeah, absolutely. And as you say, if you look at women in their 50s, you know, 1 in 8, but 23 women in their 50s are going to develop breast cancer over a 5-year period. If you look at some of the newer forms of HRT, it's 2 or 3 extra cases. But as Kelly said, if your BMI is over 30, it's an extra 24 cases. If you drink more than 2 units of alcohol a night, so 2 standard drinks a night, it's again an extra 5 or 6 cases. So it's more risky being overweight and drinking more than 2 glasses of wine a night than taking some of the newer HRT. So putting it into perspective is extremely low risk. Yeah.
I'd be interested in doing a little poll of our attendees at this point, Katie. I might actually, I'll get rid of this one. And let's go to a different question now. I'd like to know whether or not any of the ladies, or how the ladies in the audience feel about taking HRT, who would consider using HRT. I guess there's probably a lot of them in the audience right now that are already on it. And I think, yeah, overwhelmingly it seems to be yes. So probably should have asked that question before we had our discussion about how safe it was, shouldn't I?
Yeah.
So yeah, it seems to be overwhelmingly yes in the audience. And I'd be really interested to sort of know of those people who've decided definitely no. You know, I mean, obviously there could be people out there who have had breast cancer or have other contraindications, and that's absolutely true. You should not use HRT if you've had a hormone sensitive cancer. So, you know, there's going to be people who absolutely can't and shouldn't take it. And then so we can get on to looking at now some of the other options, I think.
Kelly, when you're taking HRT and you've just started it, what is the time frame when your symptoms are kind of going to stabilize by using the medication? How long should you give it to kind of really judge it?
What do you say to that one, Katie?
So in general terms, I say 3 months for any new treatment gives your body time to adjust to it and balance out. In saying that, things like the flushes and sweats often improve quite dramatically, quite quickly once you're on the correct dose. And people often say, gosh, I took it for 2 weeks and I felt so much better. So you don't feel you have to wait for 3 months to notice a difference. That's not the case. It's just on that particular regime. Maybe just give it 3 months to balance and settle out. But I would hope you would be feeling a lot better much sooner than the 3 months. Is that what you...
Yeah, I agree. A lot of women, and it depends on the person, you know, there's a lot of things that can cause hot flushes and night sweats. And if they've come on just as your periods got erratic, then there's a fair chance that it is related to your hormonal changes. But it's not everything. You know, there are a lot of women I'm seeing in the chat box there who are saying it didn't work for them. And they're saying, what's MHT? It stands for menopausal hormone therapy, which is just a newer term for hormonal replacement therapy. So yeah, I think there's a lot of difference in how women's bodies react from product to product. But you know, if somebody's had a very sudden or a very early or a surgical menopause and are really getting quite debilitating hot flushes, those are the ones that often you see a very dramatic, very rapid improvement in certainly their vasomotor symptoms, their flushes and sweats.
Yeah, for sure.
Okay, so we've had a bit of a chat there, and we've got a pretty fair idea of the things that HRT can help. What about non-hormonal therapies? Because a lot of people can't or don't want to take hormonal therapies. So there are a range of other medical approaches. We already talked earlier about the things you can do non-medically, like in controlling your environment and avoiding things that make your flushes worse. In terms of medical treatments, they tend to be, as you would imagine, they tend to be medications that act on your brain chemistry, because this is where flushes originate from. There's a theory that they present at the menopause conferences, that the reason why we have flushes is that at menopause, the hormonal changes narrow our temperature tolerance range. So it doesn't take very much to push you over the top, like having a hot cup of tea or moving into a very warm room or something can set off your flushes. And it's because of changes in the brain. So other medications that change your brain chemistry can help to stabilize it, like some of the SSRI antidepressants, some anti-epileptic medications like gabapentin and clonidine, for example. And of course, a lot of ladies will ask about using alternative or what they perceive as being more natural therapies. On the whole, most of them don't have a lot of evidence for efficacy, nor do they have a lot of evidence for safety. So this is the difficulty. You may find that some people will use these products and anecdotally they say they feel better. We have got some evidence around things like black cohosh being mildly effective, but nowhere near to the extent that you'll find estrogen being, because of course, your body's in estrogen withdrawal. So if you give your estrogen receptors some estrogen, they'll feel better. So, it's not as effective. Certainly, by all means, I'm happy for my ladies to be trying some things if they want to, as long as I can assure them that it's not going to do any harm. And in a lot of cases, that's the tricky part. So be very, very careful when you're looking in the complementary and alternative space. Have a look at some of the evidence that's presented on the AMS website about that, and be mindful that you might be putting a whole lot of money into something that's not actually been demonstrated to be terribly effective. So what it comes down to is really just be well educated and well informed, and make sure that your GP knows what you're taking, regardless of which path you go down of treatments. So for being informed, I just wanted to give you guys a plug for our blog site. As I mentioned earlier, we did a bunch of webinars last year on a range of topics: bladder problems, mental health issues, sleep issues, diet and exercise, sexual problems, libido, a whole bunch of stuff. So these blog posts that you see on our blog page, a lot of them from last year will actually have a webinar embedded in there as well. So if you're looking for some information, that's one source I can recommend. Likewise, we've got sources like the Jean Hales website. Jean Hales has some fantastic resources about menopause. And in fact, it is Women's Health Week, which was initiated by Jean Hales, actually officially next week, but that's why we're prompted to do these webinars now for you. Also, the Australasian Menopause Society, which I've mentioned a few times. This is kind of their menu along the top. And if you go into the consumer information, you can see all of the resources and fact sheets they have, and the Find an AMS Doctor spot if you're looking for someone in your local area. What else have we got here? Oh, yes. So just to finish up, I'd like to know what you all think are good things about menopause, because I hear a lot of negative stuff about menopause. What about you, Katie?
Yeah. I mean, we do hear a lot of negative stuff, but actually it's a time where women can take control and feel quite liberated as well, I think. So it's a bit of a transitional time in people's lives. Yes.
Yeah, absolutely. So I'm going to pop this one up there. I'd like everybody to name what they think is a positive thing about menopause. And this one's just a free text, so you can write whatever you like. But, I think for me, what I've noticed, so I went through, a pretty awful perimenopause. I was quite young, and it took me a while to put two and two together and work out what was going on. But once I realized it, and once I got those symptoms well managed, it actually is liberating in lots of ways. I've found since that time, you let go of a lot of stuff psychologically around menopause. I guess you start to care a whole lot less about what people think, which I've found quite liberating. And I used to let a lot of stuff like that hold me back from doing stuff I wanted to do. So, I started WellFemme when I was 50 years old. I don't think I would have been brave enough to do that when I was in my 30s or 40s. So I think you kind of get to a point and you go, oh, the hell with it. If I don't do it now, I'll never do it. So you just kind of do. You're free from periods, you're free from tampons and pads, you're often free from, well, hopefully free from raising your children at some point, but then you might have grandkids, but you get to play with them and give them back. So, when we're allowed to, we can go traveling and do all that. I don't know. What are you looking forward to, Katie?
Yeah, I think the travel is a good thing. I think, as you say, not being tied to having a menstrual cycle every month is also a really positive thing. And I think just thinking of it as a transitional time where you can actually grab hold of your life and decide which way you want to go forwards, and have the kind of a bit of wisdom behind you, a bit of knowledge behind you to be able to make those decisions and be a bit more empowered. So, yeah.
Yeah, I agree. Michelle, what are you looking forward to?
Oh, definitely just the I think, when you kind of book that holiday and you kind of think, I wonder if that's going to be my lucky week or my unlucky week, to be able to actually just kind of not worry about that, and kind of I have been on holidays, got on holidays and thought, oh, damn it, I totally forgot to pack anything. And I just forgot. There was so much else to organize. But I think, definitely that. And I think, I love some of these comments in here about, just having that confidence and being free to be me and all of those kind of things. For those who have had kids, you spend a lot of time looking after kids, and a lot of time you push yourself and your own needs aside, and it's now a time to kind of come back into that, isn't it, and rediscover yourself and start looking after yourself, particularly right now. We all need to do that right now.
And on that, I guess, the thing about being older is you've lived through a few hardships, right? And it gives you that much more confidence that you'll be able to, that you'll get past it and you'll be able to deal with it and you'll be able to move on. So that's all we kind of had from the presentation side of the house. So I guess this is open to question time now, right, Michelle? So I'm going to let you field the questions and feed them to us because there's just so many coming in.
There are a lot coming in. It has been absolutely huge. A really interesting question is, if you have if you finished your period and that has all kind of happened, but you're still having those symptoms, can you still start the HRT treatment then?
Yeah, I mean, absolutely. There's no definitive time limit. It's preferable to start it within 10 years of your last period, but there's no cutoff that after 10 years, absolutely, you can't start it. It's an individual discussion, an individual kind of risk-benefit discussion of HRT, and particularly if you've gone through an early menopause, actually replacing your hormones up to the time that you would naturally, most women would go through menopause in their 50s, is really important for bone protection and heart protection. So there's no actual complete cutoff. So even if you feel it's been 5 years since your last period, if you're still getting symptoms, it's still worth going and speaking to a doctor and getting that advice. Absolutely. I started in women who have beyond the menopause on an individual basis really quite often.
Yeah, because even if they've been quite some years after menopause, if they've been putting up with really debilitating hot flushes that are ruining their lives, I mean, it really does come down to an individual choice for that woman. You explain that it's not as safe as it would have been if she'd have started it at menopause, and it hasn't had that good preventive benefit for those 8 years that we would have loved to have. But if she understands that, there's certain small risks perhaps in her case, and still feels amazingly better on it and her quality of life is better, then that's her choice. You've got to give people information and empower them to make their choices.
Yeah, fantastic. Are there any tests that can be done to analyze your hormone composition at all?
Yeah, we get asked this a lot. I think you'd agree, Kelly. We get asked about hormone levels. In general terms, in the perimenopause, your hormones are doing this. So actually, if I check someone's hormones now, they're going to be different than 2 hours time or tomorrow. So actually getting a hormone profile isn't that helpful. We're much better to treat the symptoms that you're experiencing. hormone levels don't tell us very much. In saying that, in some women, for example, if you are under 40, we might do a hormone level to see if it was perimenopause or something else going on. And we often do blood tests to check other things like thyroid. You know, we look a bit silly if we treated you for perimenopause and your thyroid was out of whack, which would be feeding into your symptoms. But in terms of hormone levels, in general terms, they don't really help, because in the perimenopause particularly, you can have normal hormone levels, but it doesn't mean you're not perimenopausal. Is that the way you go with it, Kelly, as well?
Yeah, absolutely. I try and avoid doing blood tests unless I absolutely need to. There are some situations, like if there's the contraception question and they've got a Mirena and we're not really sure whether they've stopped ovulating or not, then that might be a time to, you know, to just determine, yes, we're absolutely in menopause. So 12 months later, then we'll say, yes, sure, it's safe to take your Mirena out now. But, you know, or if they're particularly young, like really unusually young, and we're trying to ascertain, is it actually menopause or something else? Because, of course, it's very important then that they be on HRT to the normal menopausal age.
Yeah.
Just quickly, somebody asked for book recommendations. I saw it fly by on the chat box. So, yes, I can give you some book recommendations. I'll just let me grab them. Hang on. So some of my favourite ones is The M Word from Dr. Ginny Mansberg. I know you're looking at it backwards by the look of that, sorry. Hormone Repair Manual by Lara Bryden for those who have a more naturopathic bent. Also, Jen Gunther's Menopause Manifesto is a wonderful, empowering read. I love that. But Ginny's is really, you know, the duck's nuts when it comes to really good, useful, factual information. That's the book I would have liked to have written, and I told Ginny that. Moving on.
No, that's all good. Can you tell us about weight gain and how to, you know, nobody wants to be putting on loads of weight. How can you really get a hold of that and try to help that situation along?
Yeah, I mean, I think unfortunately most of us just our metabolism and changes when we hit the perimenopause, and you have more of a tendency to put on weight, even if your diet and lifestyle hasn't changed that significantly. I mean, HRT isn't a weight loss drug. It's not going to make you lose weight, but it will make you feel better if you're experiencing menopausal symptoms. And if you're feeling better, sleeping better, not aching, you know, not waking up in the middle of the night with sweats or having problems with your bladder, you're going to be much more motivated to live well, to exercise and eat well. So it can benefit things that way. But I think in general, most women have to work just that little bit harder at it.
Yeah, there's so many reasons why you gain weight after menopause as well, aren't there? Because, you know, your metabolism declines. It's harder to hang on to your lean muscle mass, and it's the lean muscle mass that you have that burns calories 24/7 because it's metabolic tissue. So if you've got lower muscle mass, if you actually need less calories, and there's also these studies that have shown that if your estrogen levels are lower, you literally do less incidental movement as well. They've done that. They've seen that in mice studies. So there's lots of reasons why you accumulate weight, but yet a lot of women don't make that adjustment of the amount that they're eating or the amount of calories they're having. So you do need to eat less and move more. There's no two ways about it. But, you know, certainly any weight you do gain will go on centrally around the organs, which is more of a risk for heart disease. I'm actually leaning more and more to, you know, different approaches like intermittent fasting. There's a lot of evidence for intermittent fasting when it comes to being able to maintain a healthy weight, because it keeps your numbers, you know, your biochemical markers in the healthier range when it comes to cholesterol and things like that. It's good for prevention of diabetes. And if you're intermittently fasting, it's keeping your overall calorie levels down too. But really, they say the best diet is the one that you can stick to. So if you find that you can control your weight by eating less carbs, or, you know, having 2 meals a day, or having smaller plates, whatever it takes.
Yeah, fantastic. A question which was submitted earlier today. Have you been trying to, this person's been trying to find out if the blind study at the Royal Sydney Hospital on Mona Lisa Touch results are out, And if you
I
know
haven't heard about that one. So I knew that, so Dr. Abbott, Jason Abbott in Sydney was presenting about that one at the Menopause Congress, Katie, a couple of years ago. They were recruiting for it back then, so I dare say that it's either well progressed or finished, but I really don't know. And certainly I haven't heard about the results being released yet, but maybe they'll tell us something about that one at the next Menopause Congress in November.
Yeah, sure.
Yes,
No,
so sorry, don't know yet.
I'm having my Mirena removed in October and are currently using Sandrina gel. What do I do or use afterwards? I'm still having hot flushes, muscle joint aches, and a few headaches as well.
I mean, I guess, you know, in general terms, you can have your Mirena replaced. I don't know if it's just being removed or being removed and replaced, but it's licensed for the progesterone part of HRT for 5 years. So if it's coming out and you're not replacing it, you can continue with Sandrina gel, but you're going to need to add in another form of progesterone. So whether that's a Prometrium or you know, a combined patch or whichever way you do it, you're going to need progesterone as well as the Sandrina gel. But there's no need for you to stop the Sandrina gel just because the Mirenas get coming out. So if you don't want another Mirena, really important you get another form of progesterone prescribed.
I agree.
And is there anything you'd suggest for really severe mood swings, being really angry? It's one of those.
That's a great question, isn't it?
Very prevalent right now, isn't it?
Well, I'm thinking, you know, like just lock the kids out of the house, but you know, that's just one solution. And I think that's one of the reasons why alcohol sales are through the roof during COVID, isn't it?
Absolutely, yes, yeah. I mean, again, I think most of the women I speak to say, I'm so irritable, I'm so cranky, you know, things I just take in my stride, I just blow off, fly off the handle with. And I think the vast majority of women I speak to have some kind of mood disturbance. And I think if it is, obviously lots of things can cause mood disturbance. So it's really important to make sure you're not clinically depressed or, you know, lifestyle, all those things going on in your life that you can't alter. But if it's due to hormones, I think balancing out those hormones do make a massive difference to mood in general.
Yeah, absolutely. I mean, you know, it's kind of like that slide we showed earlier with you've got to take that holistic approach because there's going to be lots of other contributing factors. But when you take all those other things out of the equation, if you've got a woman who's, you know, always been quite level and never really had too much problem with mood issues before, and then all of a sudden she's having erratic periods and having, you know, homicidal rages or something like that, with nothing else in her life changing, that's highly suspicious that it's hormonally related, isn't it? So yeah, again, it just comes down to sort of trying a few things and seeing what works for her.
Yeah,
sure. Someone has written here, I heard that the onset of menopause and HRT can make rheumatoid arthritis worse. What is your take on this? And I've definitely noticed a few things in the chat as well where people have been bringing up a similar issue.
So I mean, autoimmune isn't like things like rheumatoid aren't actually a complete contraindication. Again, it's an individual discussion. Estrogen itself can sort of flare up the immune system a little bit. So we take everyone on an individual basis and can be a bit cautious. So things like lupus that affect lots of body systems, you know, we might be a bit more cautious about prescribing HRT. But things like psoriatic arthritis and rheumatoid, I generally prescribe fairly freely and generally have no issues with it. I don't know what your experience is with that, Kelly.
Yeah, I always mention that possibility. You know, estrogen's an immune system primer, and you know the studies are showing that women die at lower rates from COVID if they're on MHT than if they're not. So that's how much of an immune system difference it can make. And women, incidentally, actually die at lower rates than men from COVID too, by the way. So estrogen is an important player in the immune system, clearly. And yes, for some conditions, they can possibly see a flare, and SLE is one that's mentioned often. So for anyone who's got an autoimmune disease, I do mention that possibility that if they get a worsening of the or a flare-up, that we might need to pull them back off it.
Once you start HRT, is that it? Do you just kind of keep going, or like when do you know that you can stop it?
That's a great question, and that's one that a lot of women ask because they go, does this just mean that I'm just putting off the inevitable, and when I come off the HRT, the flushes and stuff are still going to be there forever? And the answer is, well, not in every case, that's for sure. I think there are the occasional women that still, you know, into older age are still getting flushes if they don't have some HRT. And all the specialists talk about these, you know, having a little old lady on the books who's in her 80s and still on a minuscule piece of a patch or something. But, you know, the reality is for most women, I think the average use is around 6 years. Is that right, Katie? About 6 years-ish?
Yeah, and I think again it depends. You know, if you're starting it at, if you have a hysterectomy at 35, we tend to keep people on it up until the age of average menopause, which is in your early 50s. But it doesn't mean you have to stop it then. You can actually continue it quite safely going forwards. Lots of safety data up to the age of 60 and beyond if need be on an individual basis. We just make sure you review it once a year and all your kind of risk factors are taken into account. But there's no time you absolutely have to stop it.
Yeah, no, I think,
sorry, I was just going to say.
Yeah, sorry, you go ahead.
I was just going to say, if you wean off it slowly and your symptoms come back, you know you're not ready to stop it, so you can carry on at that point. Sorry to interrupt, Kelly.
Yeah, no, I think it's about, you know, different women and how their bodies adapt to the lower levels of estrogen. It's kind of, you imagine it like your body's been used to having this hormone. Let's think of it like as though it was a drug, right? So your body's used to getting a supply of this drug, and then all of a sudden it's gone. The hormone receptors, you know, are screaming out for food, and it takes a while for the body to calm down and get used and adapt to those lower levels of estrogen. So women will make that adaptation at different rates. And so if they come off their HRT still getting symptoms, then yeah, sure, go back on HRT sooner rather than later, because the safest way to use it is to use it as long as you need it from a young age, and use it continuously for as long as it's needed. But when you do go back on it again, you know, if you've been on it for quite a while, it might pay to actually try going back on a lower dose and seeing if you can make do with a lower dose and gradually step it down, as you say.
Yeah.
Interesting. Can a Marina disguise menopause? No periods for 12 months, last 2 months heavy bleeding again, and so many other menopausal symptoms too. Like if you've got a Marina, how do you know that you're going through menopause?
Well, yeah, that's a good one. I mean, if you're using just the periods as a visual marker, then yes, that's going to be tricky. But usually it's not just about the periods. Usually it's about the symptoms that women are getting as well. So, you know, I mean, it doesn't matter to me whether a woman is menopausal or not. If she's having symptoms, you know, and we're pretty sure it's hormone related, then we're kind of going to be treating them the same way regardless. That's why blood tests aren't that important. The only real reason to know where the Marina is concerned is to know that she's stopped ovulating, so it's safe to take it out for contraception. So I guess, you know, is it important to know in the first place whether or not they're menopausal is the question. What do you think, Katie?
Yeah, I mean, you may not know because, as Kelly says, you can't rely on it. If you're having no bleeding, you don't know if that's because of the Mirena or because of something else. I mean, in general, we would leave a Mirena in till 55 or 56 and then remove it at that stage, because the vast majority of women will have gone through menopause and completed it by then and have no periods. But yeah, there isn't an exact way to know, pinpoint when your last period was, because you don't know, because of the Mirena stopping them, you don't know when your last natural period would have been.
Yeah,
interesting. Just back to weight loss. This person's taking HRT, feel good, except the weight not coming off. Doctor said it's a side effect of the HRT. Is that correct?
No. No is the short answer. No, not really. Estrogen actually, you know, although it's not a weight loss drug, as Katie said, it has metabolic effects which actually help, you know, when it comes to that sort of area, I guess. So when your estrogens are higher, you're going to have the more pear-shaped body rather than the apple-shaped body, which is healthier. So certainly fat distribution is different when your estrogen's high versus when it's low. And no, the MHT in itself isn't going to cause weight gain. It's not quite like the pill where some of the progestins, because they're in fairly high dose, can cause weight gain, and particularly things like, what is it, Depo-Provera, hasn't it been shown to make people gain weight, Katie? But those are much higher doses. So we certainly, we don't notice anything like that. But if people are on a particular type of combined hormone therapy and the progestogen that they're using, which might be a synthetic form of progesterone, if it's not agreeing with them, if they're getting nausea, bloating, moodiness, reflux, whatever, maybe they're sensitive to that one, and maybe it's not doing them any favors in that respect. Yeah, Katie?
Yeah, I mean, I think the only hormone, as you say, is the Depo injection that's been proven to cause weight gain. I think women tend to blame their hormones for weight gain, but actually that most of them are completely weight neutral. You might notice a little bit of fluid retention possibly when you start, but that usually levels out. So I wouldn't blame the HRT for weight gain. It's probably lots of factors feeding into it, but it doesn't cause weight gain as such.
Mm-hmm.
Might be the croissant that I'm having at the bakery as we go for our exercise in the morning. But anyway,
that one was not prescribed.
Yeah, damn it, I was going to blame something else. If you have kind of a variety of kind of medical issues going on, so things like thyroid issues or anxiety and depression and those types of things, how do you pull it all apart and really figure out what's going on? What process would you take, your patients through to try and get to the bottom of exactly what's happening, and of course, how we can help?
I mean, I think sometimes you don't know 100%, you can't unpick it fully, but sometimes giving a trial of HRT and looking at that menopause symptom score that we talked about earlier, if that improves on HRT, it's improved. So sometimes it's just seeing and assessing a response and seeing if it makes a difference is the best way to find out. And in general, a 3-month trial of HRT is going to do the vast majority of women. It's a really safe thing to do. So it's worth a trial if there's a possibility that you're perimenopausal contributing to your symptoms. And if it helps, brilliant, then you kind of got your answer there.
Yeah, absolutely. I agree. There's, we're complicated creatures, and there's so many things that are contributing to our symptoms and how we perceive our symptoms. So, and there are women who, will come along with a bit of story, and I go, I'm not so sure that this is going to be the answer for you, but hey, it's not an unsafe thing to do. You're going to have your question answered in a few months' time, and if that's not working for you, we can move on to something else.
Yeah, awesome. Is there any hereditary nature to menopause? Is it that, what your mum went through, is that similar to what you're going to go through?
I think they've shown closer links with sisters, actually. Certainly I do hear from women that, my mum went through an early menopause and I did too. So, we do know those genetic links are them, but I think it's more indicative, that if your older sister went through an early menopause or a later menopause. Mm-hmm.
Yeah, interesting. We've just got a question here if this webinar is actually being recorded. Yes, it is. And the good news is that you're going to receive a copy of it tomorrow morning after we finish editing what we need to do to it and getting it all nice. So, yes, it will be available. So anyone who wasn't able to join us tonight, and likewise, if you want to watch this back and go through it again, or maybe get your partner to watch it, or those types of things, then it will absolutely be available for you. So that is all good. We've had someone using fasting and keto, 2 meals a day works for them. Mm-hmm. Just having a look through here. Are the symptoms kind of guaranteed if you kind of don't have hot flushes, for example, which seems to be one of the main symptoms? Are you kind of almost certain to get those at some point, or not necessarily?
No, as you saw from that pie chart earlier, about, sort of 10 to 20% of women don't actually cruise through without much in the way of symptoms at all, which sounds amazing. But yeah, there's a very big difference from person to person. Some people will have predominantly hot flushes and night sweats. Other people will be predominantly mood issues. And when it comes to treatment of symptoms, there are a couple of classic medical indications for using HRT. Generally speaking, it's debilitating hot flushes and osteoporosis, because estrogen therapy is a really good treatment for both of those things. But the reality is, all of us in the menopause space will talk to women about the use of HRT for a variety of different things. And so it comes down to sometimes just doing a try of things, even if it's not a classic medical indication. If it's clear that the woman's got symptoms that may be related to their hormones and it's safe for them to try something, we use it often, in what's called an off-label use, rather than, the strictly medically indicated use.
Yeah, sure. No, that's really interesting. Now, we have had a few comments. People have kind of jumped onto your website, had a look, and appointments are a little bit hard to come by. And that is a result of a big increase in demand because Kelly was on 60 Minutes. And what we have actually done is we understand that this is the situation, but we want to be able to help you. So Kelly is working very hard with her team to be able to increase more appointments. Currently, the wait time is for a couple of months, and we really don't want you to wait that long. So what we've done, and I'm just going to pop it into the chat box, there is a quick waitlist form. It's literally just your name and your email address that you put in there. And we can keep you up to date on as soon as we open these new appointment times, because Kelly has got some great team members joining who are also extremely experienced in this area of medicine. So watch this space, because we are going to be opening up some appointment times soon. And we've got a lot of people from across Australia. Just to remind everybody that WellFemme is a clinic which is a full telehealth clinic, which is simply amazing, because what it does is it gives you the ability to book appointments at your convenience, and you can have either a phone consult or a video consult, so you don't even need to leave your house to have these appointments, and you get to speak with Kelly, Katie, and the other practitioners that are a part of WellFemme. So please pop your name down on that wait list, and we will make sure that we keep you absolutely up to date with when those appointments become available, and we'll send out emails quite regularly for that. Now, another question here. Do you want to add to that, Kelly, or?
Oh, no, I'm just so excited that, that women are waking up to the fact that, some of the things they're experiencing might be related to perimenopause and menopause, and that they might actually be able to get some help for that. And we've found some fantastic doctors who are really keen to work with us in WellFemme, and really keen to help these ladies. So I can't wait to hook them up.
Absolutely. Now, any suggestions for being teary all the time? Not so much sobbing, sad, crying, but just eyes leaking, wobbly chin, unhappy, sad type scenario.
I wonder if is that under emotional circumstances or just like at the supermarket?
It's getting ridiculous, apparently. Never been cryier, if that's a word.
All right. Yeah. Look, I should be on that too. I blub, at Huggies commercials, seriously, ever since I was pregnant. And I'm on HRT. So, look, I don't have the answer to that one. I'm sorry. I think, just one of those things that happens.
Yeah, it's emotion, it's life, isn't it? So
embrace it. Embrace all of the vivid colours of life, all the different emotional experiences.
Yeah, absolutely. Kelly, help with vaginal dryness. What can you do about that? Is there any quick fixes that you can recommend?
Well, as Katie was talking about earlier, if it's related to low estrogen and they've got thinning and drying of the tissues of the vagina, which is, its terminology is vaginal atrophy, which sounds terrible. But, it's usually, if it's thinning and drying and fragile, if there's like sandpapery feeling or tearing during intercourse, then that's absolutely fixable with some estrogen. So some, topical estrogen we're talking about. So even without using a patch or a gel or a tablet, you can actually use a pessary or a cream directly on the vaginal tissues, which will very, very quickly make them plumper and more resilient and moist. So, less prone to damage. And that can happen, just from using it every day for a few weeks, and then you can drop it back to about twice a week for maintenance. Then on top of that, I would always recommend using the proper lubricants for intercourse, because, everybody can get micro damage during sexual intercourse. So it really helps to be using a lubricant, usually an oil or a silicone-based one for sexual intercourse, and a water-based one is really great for just everyday dryness because it absorbs well into the tissues.
Yeah, absolutely. Now, without a crystal ball, those of us with mums who've had breast cancer will never know if their HRT caused their breast cancer, right? So, what do you recommend in those kind of situations?
I would say normally if you've got one first-degree relative and you don't know that you're a carrier of any gene, like the BRCA gene is the common one, if you've got a mum or someone who's developed breast cancer at a later age in their 50s or 60s, your background risk is probably not that much higher. If you've got several relatives, you might have a slightly increased background risk, but adding in HRT doesn't make you more at risk than anyone else adding in HRT. So your overall background risk might be slightly higher because of your genetics rather than adding in the HRT. So unless you're a carrier of a genetic BRCA gene, or you've got lots of relatives at young ages who's developed breast cancer, you can be reassured that we do quite often prescribe it, and it's quite safe to do so. Just bearing in mind, if anyone was develop breast cancer on HRT, we'd never know if you were one of the 23 in 1,000 or the extra 2 in that 1,000 who develop on HRT. There's no way of ever knowing that.
Yeah, a breast cancer isn't going to develop just because of HRT. There's been genetic triggers and processes at play there. Certainly if you're the 1 in 8 that we were talking about who develops a breast cancer and you don't get off the hormones, then the hormones will feed the cancer. So that's why early detection is so important. But the development of cancers, like everything else, is multifactorial, and all those lifestyle things and environmental things and everything else is contributing to that. So it's impossible you just can't say HRT caused this cancer. That's if you're going to be a user of HRT, I think you have to realise that, the only information we have is based on the studies, the evidence from these studies, which are huge populations of women, and the effects of any kind of HRT, even the most risky kind, is still very, very small compared to any of these, lifestyle factors like drinking and smoking and being sedentary and being overweight. So, I think you can't really kind of say, for sure at any time. And obviously if you're the 1 in 8 or you've been on HRT and you've developed a breast cancer, that may be cold comfort. But I think anyone who's going to start HRT needs to be very mindful of all of the facts around that and mitigate any risk that they might have by optimizing their lifestyle factors and doing really big, rigorous screening.
Yeah, really interesting. Can we talk about libido?
Yeah.
We've had that question here. Where do you start to figure out how to manage low libido levels?
What do you do, Katie?
Yeah, so libido is an interesting one because a lot of women come to us in their, say, their 40s and 50s, sometimes younger, sometimes a little bit older. And usually women at that point in their life have so much going on. So, work, not working, families, house running, and you're pulled in every direction. And often your relationships and your sex life take a back seat on that. So you kind of have to be mindful of all that going on around you. But it's really important, I say, to have a comfortable vagina, because if your vagina is dry and sore and it's painful to have sex, you're not going to want to have sex. So that needs sorting out. HRT, being on adequate estrogen, if you decide to go on that, definitely helps improve your libido, but it's not an overnight fix. You have to kind of put everything into play as well with that, everything else going on. And sometimes, you know, you're never going to get back to the libido you might have had in your late teens or early 20s, if that, you know, it might never reach that level again. But in general, if you can get be comfortable when you're having sex, not be in pain, and be sleeping well, rested, your libido tends to go up, albeit a bit slower than some of the other symptoms that we treat with HRT.
Mm-hmm. Yeah, absolutely. The webinar that we did last year on sex and libido issues, the points that I made particularly about libido there was around we presented some data there that low libido in midlife is absolutely normal. So, you know, if you're out there going, oh, there's something wrong with me, I'm not horny all the time, I don't want sex as much as I did when I was 20. Well, I've got bad news for you. That's normal. Like that's the majority of women. It's, you know, almost, I hardly ever see 0 on that thing in the scoring sheet. You know, it's usually 3 out of 3 loss of libido. So that's absolutely normal. And I think it pays to think of it more as a management issue, because as Katie said there's all of these things that take priority in our lives well above, sex. And if there's anything that's stopping you from enjoying sex, like pain, or you don't think you're going to enjoy it very much, or you think it's going to take forever for you to orgasm, or one of those things, then there's kind of not a lot of incentive to want to engage in it, because you just think it's going to be a chore. So I think you need to think of it more as a management issue. You need to have what Dr. Rosie King calls decision-driven sex rather than desire-driven sex, because you're not going to feel spontaneously horny. What happens for women after a certain age is that when you give yourself the opportunity to engage intimately with your partner and you let that arousal grow, then you start to want to have sex. So it's, cart before the horse, kind of situation. You need to actually engage. You need to make that decision to create the time and the space with your partner to be well rested, enjoying each other's company, and then make that decision to have a kiss and a cuddle and see where it goes. And then you become aroused, and then you want to do it. So, and explore your own sexuality a little bit, buy a vibrator, fix up the sore vagina, get some, lubricants and things like that. Start looking at things a little differently. So if what you're doing now isn't working for you, then just think about, how you can explore enjoying intimacy a bit better with your partner.
Yeah, interesting. This is a really great question. And I think, Kelly, with your recent experience on 60 Minutes and how that came all about, might come into play here. How can we help normalize this time of life and the symptoms? And this lovely lady said, I talk about it so much and I think I come across as a little neurotic. So, and I know the background story of, how 60 Minutes came about and why they wanted to raise the profile as well of this issue. Can you tell us about that?
I think we're doing it right now. I think we're normalizing it right now. I think when there's a time when it can be discussed in the workplace, without men cringing and running away or going, "Whoop, that's me out." I think that we've got to help educate our daughters and our sons about that, because we missed out on getting that handed down to us by our grandmas and mums in most cases. So I think that's it. Is like, if you let your family and friends see what you're going through and how you're dealing with it and talk about it with them, then it won't be scary.
Yeah, absolutely. No, that really is very interesting. We've just got a message. Can we email the link? Yes. The wonderful world of automation is that you'll get a link to the wait list.
Link for everything.
Which was sent out at 8:30, so it should be in your inbox right now. So just letting you know that is definitely there. Watching 60 Minutes has opened my eyes. Thank you. I think there's a lot of saw Dr. Linda last week. She was amazing. Thank you, WellFemme. So it's lovely to hear. And, that's what WellFemme is all about. It is about helping women all across Australia, no matter whether you live in the cities, whether you live in regional areas or rural areas. You know, if you don't have a lot of choice when it comes to your general practitioner, particularly when it comes to feeling comfortable talking to your GP about these issues, then that is where WellFemme can come into play and really help you in that regard. So bear with us.
That, Michelle, I'd like to make the point too that we really strive to work in collaboration with ladies GPs as well. Like we are GPs ourselves, but we're not working with these women in a general practice role. The GP that you see every day, you need to foster a fantastic relationship with them, because they're the ones with you every day, helping you through all your medical issues. And so it's really important that they understand, you know, what you're going through. And so when we send back your very detailed report, it's important that you share that with your GP so that they understand the reasons why you're using these things or trying different things. So it helps to educate them, and it helps make sure that they're on board and that there's good collaboration between us all, so everyone's on the same page.
Yeah, absolutely. And there was a question that came up in the chat. Do you educate GPs? And the answer is yes, WellFemme does. So Kelly's running a session with general practitioners next week. And there's definitely a lot of GPs that are kind of very interested to kind of learn more about this area. Because, you know, being a GP, there are so many different ailments. You think about all the things that patients go to GPs for. There's so many ailments that they need to be across. Sometimes we just need to find that right person that has that core interest in this area of medicine. So, you know, definitely do your research there for sure. Absolutely. Well, we have lots and lots of questions still. Shall we keep going? If we've still got a lot of people on this webinar as well, but
I've got some more questions. You up for that, Katie?
Yeah, that's all good. Yeah.
It's been a long day, hasn't it?
I've just got a comment here. My GP's eyes lit up when I told him about WellFemme. He jumped online to check it out whilst I was still in the room. He thought it was a great idea. Fantastic. That's lovely. No, that's really good. What a lovely comment. If you've suffered a stroke, is it safe to take MHT?
I think it can be, is the answer to that. There's lots of different types of stroke. Again, that would be a very, very individual thing. But transdermal HRT through the skin is actually stroke risk neutral. So that would definitely be the only one that I would probably go for, but it would be a very individualized thing. We'd have to talk a little bit more about the circumstances around a stroke, but certainly women who have had strokes doesn't automatically mean you can't have HRT. You can definitely have the discussion around it. Yeah,
it depends on all those other factors we mentioned earlier, like how far postmenopausal is she. But if she's perimenopausal and doesn't have a whole lot of other risk factors, then it may well be safe, yes.
Yeah, interesting. I've got a question here. If someone has been in the unfortunate situation where they have experienced breast cancer, you know, what are their options after that? It, I guess, narrows the options right down.
Well, only with respect to treating hot flushes. So, you know, and there are actually some very good things like those non-hormonal treatments I mentioned earlier that have some really good, strong evidence that they're effective against hot flushes. So, you know, there are other things that we can use for sure.
Yeah, fantastic.
There's actually really good, I'm not sure if it's limited to Victorians, you might know this, Katie, but the Royal Melbourne Hospital has a specific clinic for menopausal symptoms after breast cancer. It was set up by Dr. Martha Hickey there. And I don't know if it's just restricted to women who are in Victoria, but it would be worthwhile asking the question, at least if you're a Victorian, and I know they do telehealth too.
Yeah, and there's some very good information on it. There's a menopause lady in the UK called Louise Newson, and she's got a particular podcast on breast cancer and HRT as well. That's worth a look at and a listen to. So you can Google her, and that comes up as well. So that's what
I love Louise.
Yes, brilliant. Yes.
Another question, just wondering, is it true that, and excuse my pronunciation of this, is it bursitis is normal with menopause?
Not typically. I mean, bursitis is more common with aging, for sure. It's a musculoskeletal complaint which causes inflammation of, some of the soft tissues around the joints. I wouldn't say it's necessarily more common with HRT unless it was caused by some autoimmune condition that was changed by their menopause in some way. I haven't heard of that. What about you, Katie?
That has a link with HRT in particular because it's a little sac of fluid that lies inside your joint. So it's more associated with arthritis and things like that rather than with menopause itself, I would say.
It's very common just with biomechanical abnormalities. So, if you, that's why, you can treat the bursitis with a steroid injection or something like that, or even surgery in extreme cases. But often physio is the fix to that because you need to correct whatever biomechanical problem there is that's putting extra strain on that area.
Yeah. What about skin problems? Is there a thing, menopausal acne? Is there a skin issue that is common?
I mean, I think I see a lot of women with a flare in acne in their 40s, quite commonly in late 30s. And I think sometimes it can be hormonally sort of mediated. Sometimes balancing out hormones can make a difference. And you can use the standard sort of acne treatments for that as well. But yeah, often in that age group, I notice that people come in with a flare in skin problems, dry skin, but also sometimes with acne as well. Yeah,
the reverse puberty thing.
Yes.
Yeah, no, that's interesting, isn't it?
Watch out, because a 15-year-old will steal your zit cream.
We've got a comment here. This person's located in a regional area. Feel very alone in a health sense. There's no need to feel that aloneness, I guess, anymore, because that is what WellFemme is all about, and that is the reason why it is available via telehealth. Because Kelly very much has recognised the fact that there are women who are suffering from often really debilitating symptoms because they may not be comfortable talking to the local GP that is only there for 12 months and might be male, and they just don't feel comfortable with that. So I guess Kelly recognises that, and that is really what the whole WellFemme movement is about, is to help people get access to the help that they need, and that is what it's all about.
And there's communities too, online communities for people who are, say, Facebook users, for example. There's really great menopause support groups on Facebook that you can go to. So the Perimenopause and Menopause Support Group Australia is one really big group that's really grown in size in the last couple of years that I know of. So definitely look for other alternate ways of getting that support, because obviously if you've got other women of menopausal age in your area, you're not the only one going through it. That's the point. Maybe you're the only one talking about it. There are movements all around the world, like the Menopause Cafe movement, that you can jump on board with, where you can actually just get together groups of women of certain age, or just people who are interested in talking about and learning about menopause, and have your own little pop-up little tea parties in a local restaurant or whatever, or virtually during COVID times. So whatever you want to do, but you can create community around that just by talking to other women.
Yeah, fantastic. It's a great idea. Can sinus issues be related to menopause at all? There seems to be a few people in the chat here that have had these kind of symptoms together.
Well, it's an interesting one, because I was reading the book I mentioned earlier by Lara Bryden, the Hormone Repair Manual. She's a naturopath. So she talks a lot about how perimenopause seems to be a time of histamine dominance for women as well. So there does seem to be something to do with histamines and allergies that seem to be more prominent in, from perimenopause. So I really do think that there probably is a hormonal influence on that. Do you know much about this one, Katie?
Yeah, I mean, I think you're right. I mean, I think that I see it occasionally. It's not quite such a common one, and it's worth trying all the standard treatments for that. But if you're having other menopausal or perimenopausal symptoms as well, again, just trying a little bit of HRT and seeing if it helps, seeing if it makes a difference. You'll soon know whether it is that or not. So I kind of say don't exclude any symptom. It can all be parcel of menopause. Everybody's different, but you'll soon know if you treat it and it gets better or not.
Yeah, fantastic. No, that's great. I think that is pretty much, we've come to the end of most of the questions. I just want to say thank you, Kelly, and thank you, Katie, for giving up your time this evening. I think this has been absolutely invaluable. As we mentioned at the start of this webinar, we've had over 550 people register for this. There is clearly a big need to have these discussions and, to get all of this out in the open. Absolutely. So thank you so much for your time. Is there one final comment you would like to leave everybody with?
I do see that women are starting to feel empowered around this topic and actually being far more proactive in advocating for themselves, seeking information. And I absolutely love that. So, I think you definitely are what you think. And if you give yourself a positive attitude around menopause and don't focus so much on the negative things, stay focused on what you can do and how you can optimize what you have. I know it's a really challenging time for everybody right now, but half of the world population is going to go through what you're going through at some point if they haven't already. So there's plenty of sisterhood out there to talk to. So create those connections, stay positive, and really, stay focused on the big picture stuff to look after yourself, like your heart and your bones and your quality of life and your relationships.
That's fantastic advice. And doesn't that put it all into perspective that, we feel like, as one of the comments here, a bit neurotic talking about this, but yet half the world's population, is going to go through this. So that is crazy. Katie, do you have any wisdom?
Yeah, just don't be afraid to go out and ask. And if you don't get the answer that you want, make sure you ask someone else. And then if you don't get the answer that you want, come and talk to us. We're here to help. So yeah.
Yeah, absolutely. And please keep an eye out for that email that has gone out this evening. It has a link to the wait list. We will make sure that that is a priority wait list so that we know who is really interested in those appointments. And as soon as there are appointments available, which will be as soon as the coming weeks, we will definitely let you know, because we want those people who need help to be able to access that help. That is really important, and that is the aim going forward. It's time to start to look after ourselves and open up the conversation about this really important topic.
And thank you so much, Michelle Taylor from Marketing Practices. You're an awesome presenter. We really appreciate you helping us out on this webinar.
Oh, my pleasure. Absolutely. It's such an important issue. Thank you, everybody. We are very grateful to have spent this evening with you and to have your time. We hope that we've provided you as much information as possible to really empower you to take control over your health, particularly during this amazing time of menopause where we can start to focus on ourselves. And I wish everybody a lovely evening, and we will hope to see you again soon. Good night, everybody.
Good night.